These positions are in each county, at least I'm sure they are in Adams and Arapahoe counties. Continue to serve as backbone support for the local health alliances. So their teams have played large roles in supporting these local health alliances, especially Aurora Health Alliance, Adams County Health Alliance, and the Metro Health Alliance group. Continue to inform health policy decisions by serving in key leadership roles. Healthcare policy and financing, Colorado Access, the Blueprint to End Hunger, Covering Kids and Families, and the Colorado Health Policy Coalition. And in 2023-2024, prioritize activities specific to ensuring continuity of health coverage at the end of the public health emergency. Key partners and staff, of course, I've mentioned Wendy and the Regional Health Connector team. So here I'm speaking about Laura Dawn and Greta Macy Allen. And then this is the list of other folks that she really wanted to make sure I mentioned. Any questions on access? Okay, so priority 2, mental health. And we do have Emma who's participating here. So Emma, please feel free to speak up if I leave something out, and Heather, please, you too. The first goals, kind of 1 and 2, are this mental health and suicide prevention frameworks cross-cutting. So they were really working on kind of with a large group of Tri-County partners to engage in this collective impact approach to implement the shared evidence-based frameworks. And I don't know that I actually pulled that out as a key accomplishment because they've done so many other things. But Heather, if you are listening, could you put the links to those frameworks in the chat? Because I think they're really worth people seeing again and remembering. And I know that Emma has talked about them at some point in the past, so hopefully you know what I'm talking about there. Moving on, so improve mental and behavioral health through advocacy, policy development, and implementation and shared performance measures. And then goal 2, reduce poor health outcomes related to mental health. So just again, a sampling of the work that they've done over the past 4 years, as well as the last year. So Emma and her team put together a virtual 2-day mental health and suicide prevention partner summit. It's very well attended, very well done. It was 2 different days, about a week apart, in February and March of this year. They had over 50 community leaders across various sectors who were working to improve mental health and reduce suicide in Adams and Arapahoe counties. It was interactive. People came away with ideas about how to move forward, kind of talk about roles and responsibilities, and come up with targeted outcomes for doing that work. They hosted most recently, just a couple weeks ago, a Let's Talk About Data community mental health and suicide prevention discussion, where nearly 40 stakeholders across Adams and Arapahoe counties came together to talk and really look at mental health and suicide data. They've participated, as kind of we talked about before, in the Community Ambassador mental health anti-stigma pilot through the Metro Denver Partnership for Health. I believe you've heard about that as well. And then they've coordinated a youth mental health webinar series for school partners on mental health topics, including the iMatter program and the Colorado, sorry, let me move this, educator support program. There are a bunch of next steps, including kind of serving as the backbone support for local and regional mental health coalitions. So this kind of backbone support piece kind of appears over and over again in our recommendations for next steps. Tri-County staff and FIP staff especially do a lot of work supporting local coalitions, groups, helping them kind of, you know, in some cases it's just organize and keep focused. In other cases, for example, Melissa's work, it's, you know, how can we pull together this data? Like what is public health's strength in this particular group, and how can we use that to support the work? Let's see, number 2, continue to ensure messaging resources, tools, and assets are updated and informed by communication best practices. Ensure data, resources, tools, and assets are updated. Utilize the Child Fatality Review and Maternal Mortality Review Committee data and recommendations, and then support local and regional coalitions for overdose prevention. Emma is going to Adams County Health Department in a very similar role and will continue to move this work forward. Heather has told me that in Arapahoe County, they also intend to continue this work and seek funding for staff who will be able to do that work. Douglas County has the Mental Health Coalition as well, and I believe they are committed to improving mental health in Douglas County. I'm a little less certain on what exactly that looks like. Sorry, struggling with the mouse. Okay, so key staff. So I mentioned Emma Goforth, of course, for mental health. And then there's, as you can see, a long list of partners with whom she's worked and the team has worked over the last 4 years. Let me just double check the chat. Okay, thank you so much, Heather. Great. So Heather put in the links to the mental health framework as well as the suicide prevention framework. So please take a look at those as well. And I will make sure those are added to the PDF report if we don't already have them. Any questions for me or Emma on mental health? And of course, you can always ask us later as well. Okay, so food and health. And Jill, I know you're on here too, so please feel free to speak up. Oh, great. Thank you, Emma. So she said the Douglas County Mental Health Initiative is active and working towards some of these recommendations. Great. Thank you. Okay, so food and health. Goal 1, increase access to safe, nutritious, affordable, and culturally relevant food, especially in communities with limited resources and communities of color. Goal 2, promote food security and healthy eating habits through messaging, education, advocacy, and policy development. And here we can see kind of how those are defined. So selected key accomplishments. So this was in coordination with Wendy's team and the Access to Care, the securing of that $50,000 in funding through the Colorado Blueprint and Hunger, excuse me. The team presented to the Colorado Shines Brighter Preschool Development Grant Team with targeted outreach to 5 centers. Half of those who received outreach have either submitted an application or are now enrolled in the program, which is great. And then the last thing that I called out was just the one-on-one meetings with community-based partner organizations to discuss and identify TA and assistance. And that was done in collaboration with the land use and the built environment team. Let's see. So she mentioned that the most common topics of interest are how to incorporate food policy and comprehensive plans and development codes. So I'm sure you know, as you've read through the report and heard presentations over years, the food and health topic area looked at quite a range of food and health issues. So we're talking about, you know, how are kids in preschool, are they getting the food they need? Breastfeeding. A lot of the breastfeeding working with businesses, childcare centers to make sure they were breastfeeding friendly, including this last one, which looks at actual like food policy. So how are we getting food? Are we working with new partners? How does that play out in throughout our jurisdiction and with, you know, with our kind of traditional and non-traditional partners? Okay, so recommended next steps for the health and food, host community listening sessions to ensure all efforts, projects, and programs are appropriate and community-based. Implement community-based food policy councils to advocate for food justice policies. Review existing models from grants and other metro counties to replicate in the new health departments. Not recreating the wheel, but kind of using groups that already exist, such as Food and Communities, Healthy Beverage Partnership, and Advancing Breastfeeding in Colorado. Sustain the Colorado Healthy Farmers Market kind of program, pursuing sponsorships, funding to purchase an electronic benefit transfer machine, and maybe even pursuing 501c3 status. Continue to work with county departments of human services to consider braided funding. Continue participation with the Blueprint and Hunger, and then continue participation with the WIC and hospital collaborations. So that includes doing memorandums of understanding to distribute pumps, procedures, and just provide general support to staff and to moms. Jill has been the leader of this work. She has a wonderful team who's been very active and has remained active throughout the COVID response and onward. And this is the list of partners that she wanted to make sure we showed. Jill, is there anything you'd like to mention before I move on to housing?
Nope, I think you covered it. Thanks, Kelly.
Okay, thank you. Okay, and then health and housing. So this was our final priority. If you recall, before this current public health improvement plan, we had a public health improvement plan that had one priority, and that priority was mental health. So to move from 1 to 4 was quite a leap for us. And I think that's one reason that this final priority was deemed developmental. It was also we weren't quite sure at first what it meant for public health and for Tri-County to get involved in housing. This was before COVID, where I think a lot of the housing work and public health's role became a little more clear. Okay, so there were 3 goals: improve the quality of housing for the Tri-County population, especially for those most vulnerable in our communities; improve access to attainable housing for the population, especially for those most vulnerable; and prevent displacement of the Tri-County population, again, focusing on those most vulnerable. So selected accomplishments. I think one thing I added, Brian, was that housing is an issue that public health can help address. So I think that's been made clear to us over the last several years. Tri-County did a lot of work. We unfortunately have lost a lot of the housing staff in the past year. So Sheila Lynch was really the kind of the main lead on housing, although she partnered quite a bit with Mara Proser. And Mara, you're on here too, so please speak up if I leave anything out. But I think the housing work, again, shifted quite a bit during COVID. And I would say during the last year, as staff have left, it hasn't had, we haven't been able to continue the same momentum as we have in other areas. But some of the key accomplishments that have been done, I wanted to call attention to. And Brian, please also, Brian was, of course, the EMT leadership sponsor of this area. So please speak up, Brian. But Tri-County partnered with 9 to 5 Colorado, which I'm not sure if we've talked about them before. I'm sure we have at some point, but they're a local CBO which focuses on social justice issues, including affordable housing and renters' rights. And so we partnered with them starting fall of last year, and that worked through about the late spring of this current year. Tri-County partnered with Power Building Partnership for Health, which was a collaboration between local health departments and community power building organizations for the purpose of advancing health equity. We know that housing is one of the social determinants of health and something that comes up a lot when we talk about health equity. There's a lot more detail about what that meant, that partnership with the Power Building Partnership for Health. It's in the report. So if you're interested in reading more of the details, please look at that section. And then through a series of learning sessions and virtual site meetings, the cohort explored a variety of strategies designed to deepen the relationship and understanding of organizations involved and identify areas of work that can be leveraged to advance housing justice. So I would say a lot of the work that happened around housing, maybe not a lot, but quite a bit, was exploratory. So, what's going on in the housing justice world? What role can we play? How does housing, what does housing policy look like related to the kind of roles that we're thinking of? What do our partners already doing related to housing policy and housing justice? And then trying to figure out how we could get involved and support it.
Kelly, can I just add real quickly?
Yes, please do.
If you could go back just real
Yes.
quick.
Mhm.
Yeah, I just wanted to add, the Power Building Partnership was facilitated by Human Impact Partners. We were one of 4 locations across the country. It was Denver, so Tri-County and 9 to 5, St. Louis, Sacramento, and Long Beach. And so there were group sessions between all of the partners, and then specific sessions with those local groups. And I think this was really the focus for this year, was to work on this partnership. We didn't know what that was going to look like throughout the year, but I'll just say that we learned a lot. And then staff that were involved in this partnership, I think, well, there are staff going to both counties. So I think there are lessons learned and foundational work out of this particular partnership building session or opportunity that can be built on in each of the counties. So I just wanted to add that in.
Thank you, Brian. So recommended next steps. So continue to focus on economic security. Of course, economic security is a huge theme throughout our community health assessment, not just in 2018, but in 2022 as well. It's directly tied to housing. We know that wages are not keeping up with the cost of living. Address evictions, improve land use regulation. And then there's additional recommendations. So continue those cross-sectoral partnerships, screening, referral, and navigation. So connecting people to resources, policy and best practice research, and leveraging the role of the public health inspector. Key staff, of course, Sheila and Mara, and I think you should be on there too, Brian. And then these are the other folks that I wanted to call out. Any other, Mara, do you have anything you want to add to the housing work?
No, thank you. You and Brian covered it.
Okay, great. So that's really all. There's a lot more information in the report, including the performance metrics the population health indicators that we were tracking over time. Jan, I see you have your hand up.
Jan, you're muted.
Thank you. This was such a comprehensive report and a great presentation. And I would just like to commend you on how you accomplished what you did in the past 4 years, especially the last 3. But it's amazing to me that you were able to put this guidance document together this past year, or however long it took you, for the counties, because we've often talked as a board how concerned we were for the counties when they first said they were going to break out. And there is a lot more relief for all of us, because we're happy to see there's so many people coming from Tri-County to help guide the counties into these different issues. And the people that are coming over have such extraordinary knowledge and experience. So I think this really makes us feel so much better about where these counties are going to go, thanks to the extraordinary efforts of the people at Tri-County. So thank you.
Well, thank you, Jan. Really, I think we've done a lot of excellent work. All I did was put the template together. So it's really everyone who has worked on the FIP as part of a work group or a lead or a board sponsor, an EMT sponsor. They've really done amazing work. And we do hope this is useful. One reason for putting the names of the Tri-County staff here are to give people a jumping off point if they're trying to contact someone and ask questions moving forward from one of the counties or from a partner organization.
Thank you. I was going to echo Jan's comments. I think when you look at the entirety of the Public Health Improvement Plan, it's amazing how comprehensive, data-driven, and frankly ambitious it was. So Tri-County staff should be really congratulated for continuing the work over the last year and for being so thoughtful about the recommendations moving forward. So I think we all appreciate your hard work.
Thank you, Kaya. I'll pass that along too.
Okay, any other questions, comments? Okay, thank you, Sally. We're moving on. The next information item is a COVID and monkeypox update from Dr. Douglas.
Yeah, thank you, Kaya. Let's see if Joelle, I'm going to try to do this for one of my last COVID updates. Can I really do it on my own? Let's see. Can you guys see that okay?
Yeah.
Yeah, okay. I didn't thank Kelly, but of course I do want to thank her because I couldn't agree more with what Jan and Kaya just said about the FIP. I mean, this FIP thing has been a journey. You know, as Kelly said, when I came here, the team had already pre-selected a single topic, mental health. Huge, enormous, daunting. My very first Board of Health meeting, the board blessed it as our topic, and we were off and running, but it was just enormously big. And you could have said we were, Kaya said we were ambitious. You could have said we were crazy for then going into 4 topics in 2019. And I do think that we picked wickedly big issues. And I think while we certainly tried to monitor the data, we didn't expect we were going to change it overnight. But I think it would have been a mistake not to have picked big, important issues, whether we were going to continue as a Tri-County Health Department or try to pass the torch. And I think there's a lot of fantastic material to pass along on these 4 certainly very important topics. So, okay, I've changed my title just a little bit. It's called COVID and Other Infectious Diseases, because since I finalized the agenda about 2 weeks ago, other infectious diseases have emerged, and some of them are outlined in the communicable disease update, but I want to give you a little bit of a dive and show you how they relate to COVID. So I'm going to talk about COVID trends, and I'm going to talk about other infectious diseases. And I will mention monkeypox, but unless we get really unlucky, monkeypox is been diminishing dramatically. I'd like to believe it was all due to our public health success. I think part of it was, but it's certainly been a more recent successful venture than some of our respiratory viruses. I want to begin the COVID piece by talking quickly about data updates. I think you all got an email from our Tri-County data team, who you can tell are multivalent people. They don't just do COVID, although they certainly have been working hard on COVID during the pandemic, but they do the other work that has been outlined tonight. But we are streamlining our dashboard as of tomorrow. We're going to be only able to update it weekly, since that's going to frankly reduce a lot of the burden on the team. We'll be doing counts and rates by county, race, ethnicity, and age for cases, hospitalizations, and deaths. Very importantly, the vaccine data, since vaccines got licensed, have taken far more back of the screen massaging to make it available in an intelligible way. And we're going to be relying on the state's website for the last 6 weeks of the existence of Tri-County to tell that story. Meanwhile, on the right is the new revised state website, and they're likewise going to a less frequent updating of the data. This will also be updated data. It will still have the same things that have been displayed on other past versions of the dashboard: cases, tests, hospital data, outbreaks, variant evolution, vaccines, et cetera, et cetera. So I really want to thank the data team for being very thoughtful about how we nimbly make this transition in a way that we can rely on our partners at the state. So just wanted to be sure you're aware of that change. Next slide. Oh, that's me. I'm the next slide giver. Sorry. Okay. I mentioned variants. This is the state variant dashboard on the left, and this is in the bottom right is the CDC Nowcast model, which is a way of modeling what the CDC thinks is going on real time in different parts of the country. The state's website shows us that the turquoise, which is BA5, is beginning to shrink. And BA5 on the state's last iteration of the website last Wednesday showed that BA5 had gone from being pretty much everything down to about 65%, with increasing new versions of Omicron coming forth. The most important ones of those were BA 4.6, that's the maroon at the bottom, BA BF 0.7, and then at the very top in brown, BQ 1.1. Now, this is probably a good time to get out of the business of running a health department, because the variant nomenclature has gotten just impossible to describe. We started with Greek letters, and now we're practically getting into genetic sequences. The big theme here is that what we're actually seeing is that BA5, which has dominated the summer in Colorado, is beginning to be replaced by the new variants. leading us to the CDC model, which suggests that the ones that are really beginning to play a role, this is a model looking at our 8-state region 8, suggests that BQ 1.1 is now comprising a big plurality of the variants, with BA5 down to about 40%, with BQ1 and BF7 sort of being other major players. I'm only pointing this out to you because I think these are things that we're going to see emerge, and we're going to be hearing this alphabet soup referred to more frequently over the weeks to come. All three of these variants, but particularly BQ 1.1, demonstrates greater immune escape properties and greater transmissibility. And those have been the key ingredients since we've been living in the Omicron era for seeing new variants emerge. I think the fact that we're seeing these variants emerge so rapidly is all the more reason for the somewhat like 65% of the population that still hasn't taken advantage of getting the booster to really act on that. Because I think we're about to do maybe not as big a shift as we did right after Thanksgiving last year when Omicron blew in like a Category 5 hurricane. But I think we're going to be seeing some big changes coming up soon. 3 ways that we've continued through the pandemic to monitor what's happening: cases, test positivity, and hospitalizations. These are Tri-County on the left and state case data on the right. Now, big point to be made here was made by the Denver Post article up in the right-hand corner. Why is the COVID-19 situation so much less clear than it has been last year? And it's all got to do with who is testing, or are people testing, and where and how are they testing. And we have reason to believe that the vast majority, probably 85% of tests, are being done by rapid at-home tests. These rapid at-home tests don't get into the database. So when you look and say we're not nearly as bad the way we are right now as compared to June or last January, the answer is we know that we're systematically underestimating what's happening because we're relying on what I think is a good thing. Convenient, at home, you can do it day after day antigen test, but it makes these case trends much less reliable. I think it's therefore making the second parameter we've been following since the beginning, test positivity, all the more important. And looking at Tri-County in the red line on the left and statewide data in the blue line on the right, each superimposed on a histogram, you can see that we're moving up, certainly not as prominently as we were last spring, and certainly not as bad as we were last winter during the Omicron peak, but we haven't been at 10%, which is where we are now since the end of June. And the slope of that line is almost as sharp, that is, it's increasing almost as rapidly as what we saw again last Thanksgiving, last December, when Omicron burst on the scene. Now, I don't know whether that's going to continue to go up. You know, you can see that our records were at 30+% positivity rate. I think it's a matter of time, but I do think this is probably increasingly becoming a more useful parameter for us to follow. And then the third parameter is the one that we probably put the most stock in, which are hospitalizations. And in some regard, hospitalizations have sort of fluttered along and not been very impressive. But when we look, especially at the state data, which is about 5 days more recent than the data I was able to get on the Tri-County website, we're definitely seeing an uptick. State numbers of admissions have gone up in the past week, the past 7 days, from, actually, these are inpatients in the hospital, from 218 to 320. So we've had almost a doubling, or at least a 50% increase of people in the hospital compared to where we were a week ago. Now, this is still far below where we were last winter. Far more population-based immunity based on vaccination and natural infection. And we have much broader access to a highly effective antiviral drug, Paxlovid. So the chances of us getting back to where we were last winter, I think, is not very high at all. But I think we certainly are entering the time of year where we've now got, this is our third fall winter of living with COVID. And I think we know this is the time we have to be most cautious. This is a series of maps that I've started showing you guys in April. This is the CDC community level shown actually all the way down to the county level. And it goes sort of kind of counterclockwise, but then I had to stick, it's a little bit out of order. So the upper left is last April, and if you just squint, it's mostly green, and Colorado was practically all green. And by the time we got to June, when, as just mentioned, we began to see a peak in cases, we are seeing yellow throughout different parts of Colorado. And by the time we get to August, you can see that we're having much, much higher rates of community transmission and hospitalization. Even though Colorado was in relatively good shape compared to most states, if you look at how much green we have compared to the others, certainly compared to the Southeast. Take us to just about a week ago, early November, and now Colorado is much improved over where we were for August. But then just a week later, these are 2 weeks apart, the 11-9 map at the bottom and the 11-1 map on the right. Many parts of the country are getting more yellow and more orange, and that's happening in Colorado as well. All of that is to say we are, I think, at a time that's beginning to look like more rapid transition. This is where we stand with vaccination. This is sadly, I love this dashboard. Sadly, the last time I'll be able to show it to you because we'll have to abdicate to the state's data. Considering all ages that are eligible for vaccination, we estimate now, or at least we measure now, that 70% of our population have received a vaccine, and 15% have received an Omicron booster. I already said earlier that that's probably our big challenge, is getting people to accept the booster. And if you look at the histogram in the lower left corner, that very, very flat vaccine uptake curve did begin to show an increase, but it's not really been sustained. So a big part of the messaging that we're doing now is it's getting cold. We actually do, as I'll talk more about in just a second, have a triple trifecta of respiratory viruses. Really no time to waste to consider getting getting a vaccine that can prevent respiratory disease, i.e. COVID, as well as influenza. The right-hand slide shows you that, or the right-hand graph shows you again that we've got, as we've seen really since the beginning of the pandemic, higher rates of uptake. In our older population, we focus particularly on the 70 and above. Very, very happy to see that in all of our counties, those rates are above 85%, close to 90%. Not particularly happy to see that we only have about a third or so of our most vulnerable seniors actually boosted. Next slide, please. Oh, sorry. I keep saying that. That's me. I guess I'm talking to myself. Thanks to Alex Kellogg for giving us sort of the update about what her team and partnerships and strategies is doing. We can continue to focus on hosting both tri-county tick clinics. Through the year, we've posted almost 500 clinics, giving over 13,000 vaccines, and supported additional CDPHE fixed community sites for an additional 360 clinic dates and 18,000 vaccines given. The equity focus has gotten stronger and stronger. We're not only focusing on our populations of color, particularly our Hispanic and Latino populations, but trying to do a better job of getting to our rural populations. Since vaccine coverage not only varies by race, ethnicity, it also varies by geography. I think you're aware of the data that suggests that rural areas are relatively under-vaccinated and they're experiencing higher death rates. We're also trying to put a more familial focus, trying to get families to come in for family vaccination events, prioritizing clinics and school districts, particularly focusing on those with lower vaccination rates, and then those with marks of inequity with high rates of free and reduced lunch enrollment. One thing I really want to brag about, and thanks, Alex, for putting this in here as a testing and mass distribution program. We started this program, I guess, about February of last year, when we had the ability to get free home rapid antigen test and free mask and give out, not at our sites, but through community-based partners. And we've been able to partner with over 20 partner organizations around the community. And to date, that's grown now to 93 partner organizations. And when I use that term, what do I mean? I mean libraries, I mean food pantries, I mean churches, And we've given out now 1.3 million, that's million with an M, rapid antigen tests over that period of time. And over a third of a million, 351,000 surgical and N95 masks. And when I say we've given them out, it's very much like a lot of things we do. We don't do it, but I want to thank Chris Hauk, who's been our lead in organizing this effort, for enlisting the partners and doing just incredible jobs of organizing the logistics. We've also been doing a lot of planning, because the fantastic work the vaccine and partnership, the strategy and partnerships team's been doing needs to be passed along. And Alex Kellogg, Chris Hauk, Michelle Eskenazi, and others have really spent a lot of time figuring out how we get the baton ready to be handed off as seamlessly as possible. We're doing work around that and all of the teams that have been part of the COVID outbreak response, the EPI teams, our community outreach focus teams, continuing to grow our vaccine champion work, these increasingly recognized and visible, credible messengers in the community. We're trying to work harder than ever on this community strategizing piece that I think has been some of the most valuable work we've done. We are continuing to promote the health equity work. Grace Sulin is our health equity coordinator, has done a fantastic job, as have folks who've been working on the various COVID teams, who we call our equity liaisons. They're people who are actually doing other jobs than just equity, but equity is important to include in every job, and they've really been able to very effectively weave that into their work. We hope to pass along many of the data tools that we've developed, the equity assets and gap maps that have helped guide where we're going to do messaging, where we're going to do vaccine clinics, where we're going to be trying to give out rapid tests. We think have been extremely useful in working closely with the communities. And then finally, we have completed a community survey to better inform our messaging. We did one that should be actually July of August of 2022, looking at better ways of approaching and convincing parents to consider vaccinating children. We've done assessments of parent and guardian attitudes about vaccines, vaccine hesitancy, and we're very involved now in reviewing and improving partnerships with healthcare providers. Health departments, whether it's Tri-County or the new Adams, Douglas, and Arapahoe County health departments, can't possibly do everything that needs to be done. So a network of partners who trust us, who can work in a coordinated way with us, is really the name of the game. This is a little bit of a look back piece, but it caught my eye. It's now about 3 weeks ago, the Washington Post did an incredibly in-depth analysis looking at the evolution of race, ethnicity disparities in death rates from COVID. And what the graph on the left shows, because the major analysis the Post carried out was looking at white versus Black death rates, is that over time, the death rate among Blacks in the lighter color has begun to get closer and closer to the death rates in whites in the darker, I don't know if that's black or navy blue color, and that in the last 6 months, they've actually coincided with the death rate among Blacks actually falling below the death rate among whites. And when they looked at it in a slightly different way on the right-hand graph, with the rate among whites being held constant, and then looking at the rates among Hispanic in tan and Black and in the same sort of turquoise color, and Asian in a slightly darker color, as we get to the October of 2022, all of these racial ethnic groups have got lower death rates due to COVID than does the white population. And the big take home out of the analysis, frankly, seemed to be vaccine uptake. That while communities of color, nationally speaking, had greater mistrust and were less willing and interested in getting vaccines early in the game, a community effort to persuade community members of the importance of vaccination began to outweigh that initial concern, at the same time as we began to see what was often in some ways a politically polarized view about vaccinations, with anti-vaccine attitudes growing, particularly in white and particularly in rural populations. So one of a really stark example of a disparity that's gotten reversed due to something that who would have guessed this 2 to 3 years ago, that vaccine hesitancy / anti-vax attitudes would have made such an enormous difference. Now, I show you that in contrast to something we've been talking about really since the beginning of the vaccine era, and that's looking at rates, in this case, of death on the left and vaccination completion or vaccination coverage on the right. And what I want you to focus on is that looking at populations of Hispanic origin in Adams County and in Arapahoe County, we see higher death rates than we do among white populations consistently in both counties. And when we look at the vaccination coverage rates, I really appreciate particularly our board members from Adams County who've been asking us really, I think, important questions about how we're reaching our Hispanic community. We're still behind. And while our missing data is probably greater in Hispanic populations, it's not at all great enough to ascribe this difference. And I really think what's going on is that the promotion of credible community spokespeople in our Hispanic communities is probably not as robust as it is in other parts of the country. We've been asked by community activists to join with them, to meet with leadership of faith communities. Their feeling is that many church communities are not advocating the vaccination sufficiently strongly. And we have a meeting that's in the process of being developed to try to bring this data to bear to try to get us for a stronger endorsement. Switching quickly to the other infectious diseases. So the graph in the upper right shows you national curves and what's happened with monkeypox. And it's been probably one of the most extraordinary ups and downs in a disease that I think had all the potential for becoming endemic, and like COVID has become, and becoming something that became an ongoing problem. Now, we're not out of the woods with monkeypox. I don't want to say that, but we're in such good shape that we've actually been able at Tri-County to deactivate our incident response team, which is not to say we're not ready to reactivate it. We're certainly still involved in vaccination. Our sexual health team is just about to get going on offering monkeypox testing. We certainly want to be able to pass that technology along to our new health departments. But this is probably one of the biggest infectious disease, initially bad news, now good news stories that we've had. We haven't talked a lot about Ebola. Melissa Adair did a nice job outlining what's happening with the Ebola epidemic, which is so far only an African epidemic in Uganda. We've been involved in working with CDPHE on monitoring low-risk travelers. These are people that have been in Uganda in non-outbreak areas and have no known exposure. There have been about 50 of these folks in the Tri-County area so far, knock on wood. So far, we're not seeing any evidence of introduction into this country, even though the story in Uganda on the ground does not appear to be promising. Ugandan health ministry decided to close schools in Uganda because in the outbreak areas, because they're now having cases in children. So it's a situation that remains of major concern. What I really want to focus on, though, is the triple epidemic, the trifecta. Different people have been giving it different names, with a big focus on influenza, which the bottom line message seems to be initially it's going to be more severe than it has in recent years, as well as respiratory syncytial virus, RSV. RSV is, in the words of the chief medical officer of Children's Hospital in a press briefing with the state health department yesterday, is like nothing we've ever seen. And you can see, looking at RSV-associated hospitalizations on the left, that's national data compared to previous years. Things are at an unprecedentedly high level. Now, the good news is the kids who can get intensive care do well. There's no antiviral treatment for RSV, but supportive care does just fine. But we are in a massive crunch in terms of pediatric beds at this point. The right-hand graph shows you Colorado data, and this is mostly a preschool age issue. Older adults who've got cardiopulmonary disease do get RSV and can be hospitalized, but this is mostly a disease of kids. So it's particularly the ones 0 to 6 months, but also those 6 to 2 years and even those 2 to less than 5 years of age. Children's Hospital is putting out all the alerts possible. That's the reason Dr. Carney showed up at the press briefing yesterday. That right-hand graph, I think, really tells you a very powerful story. This is pediatric ICU bed availability. These are data from 3 days ago. As of 3 days ago, there were 3 pediatric ICU beds in Colorado. The 2 days before, there had been 0 ICU beds in Colorado. Children's Hospital is not only a resource for Colorado, it's a resource for the entire Intermountain West region, and they're not able to take transfers from other states at this point in time. The number of patients seeking emergency care in children's has on average been 30% higher in the busiest days in their normal respiratory season. And this is an earlier season for RSV than we have seen. Over and over again, I gave a lecture at the School of Public Health the other day on STDs, and the guy organizing it's a pediatric ID doc, and he said the same thing we've been hearing in the news. This is our March of 2020 as pediatric providers. What was happening in adult hospitals when COVID hit is what's happening in pediatric hospitals right now. I think the open question is how long the surge is going to go on, and whether the surge is going to be complemented by surges in influenza or in COVID. Key messages that the state's promoting right now is vaccination, not for RSV because there aren't vaccines, but rather for flu and COVID. I think maybe one of the most important messages, and I'll tell you this as a grandfather of 2 kids who have runny noses all the time, is trying to stay home when you're sick, which is, as a grandfather of 2 kids with grandkids with runny noses, it's really hard to do. But you know, most kids who get RSV actually have colds, and we're not wearing masks these days, and really trying to figure out how we can incentivize the very difficult situation of having kids in childcare or in schools not go when they're sick is really critical. The State Health Department is also recommending a number of fomite transmission steps, good hand washing, cleaning environmental surfaces. Don't drink out of the same cup as your grandkid with a runny nose, because it does appear that RSV, which is largely respiratory droplet transmitted, in contrast to COVID, which we began to realize was more aerosol transmitted. We do think environmental transmission can be important. Reminders of doing the obvious things, covering cough, mouth and nose with cough. And I do think there is likely to be a role for masking, but it's a little hard to figure out exactly where that will be. Certainly for symptomatic people who can wear masks with colds, I think that makes a lot of sense. I don't think we've got enough evidence that broader masking could make a difference or might make a difference, although I think it is very likely that masking will prevent RSV transmission. It's just who ought to wear it. And I think we're not at a point to offer broad recommendations, except to say there may be roles and times when that can be useful. So I think we are at the end of the other infectious diseases, and I'm happy to take questions about any of the above.
Thank you. Thank you for that very comprehensive and informative presentation. Jan, do you have a question?
I remembered to unmute. I have a question. How do you factor in September and October, and now you see it going up, the number of cases? First of all, there's the issue of people being tested and they are positive, but they're not reporting it because it's home testing. But these are the people that are told you can't get a vaccine for 3 months. So that automatically is going to drop your numbers of increasing numbers of vaccines. So I was wondering how you look at that, because if you can't get it for 3 months, that's going to take out a lot of people that would be getting vaccinated with the Omicron variant one.
Well, Jan, that's a really good question. I'm glad you brought it up. And Becky, I hope you're taking notes. The advice is not you can't get vaccinated for 3 months. The advice is you may not need a vaccine for 3 months. You may have enough immunity from your natural infection. But honestly, the way the curves are starting to look, I don't think there's any reason to wait. I waited for 3 months when I got COVID in the summer because I was trying to time it. I got it in July, but I think right now, the way things are behaving, getting it, even if you've been sick, makes sense. And well, Becky, we'll have to explore whether there's some misconceptions out there about that particular advice.
Well, I had heard that they recommend 3 months, but they said definitely not before 2 months. So again, there you are with the communication. Nobody knows which end is up, and that's going to cause vaccine hesitancy for a period of time, which will affect.
A point well made, Jan, that we've gotten better at communication, but we're not perfect. And identifying where the different strands of information come from continues to be a challenge.
Thank you.
Thank you. Dr. Faywell?
Piggybacking on top of what Jan said, John, it isn't just the people who test positive that don't report positive. It's the enormous number of people that test negative and don't report that they're negative. And so those graphs that show positivity are suspect. The graph that shows the admission rate seems to be the only one that you can really hang your hat on. And the questions around the various infectious diseases, especially RSV and COVID, would take a 2-hour M&M conference easily, if not the whole morning. And with a number of people yelling and screaming at each other, as you and I have seen in the past. And with the alphabet soup coming along, it's difficult to convince people that they should run right out and get a booster when the next one coming along is going to be different. And the booster might not cover that. And so that becomes a problem. There are so many things that are still going on. The question of is RSV, which nationwide is overwhelming hospitals, is there any relation to the fact that we kept everybody home? And that's difficult to really answer, but you will have those people who say that's the reason you're having this problem, because you didn't do what we said in the past, which was, don't be so restrictive. So like I said, it could be an M&M conference that goes from 8 until noon easily.
I'm going to try to quickly address just a couple of your points. First of all, Tom, very, very, very few antigen tests get reported and get into the state system at all. So you're absolutely right. If you have a bias toward reporting only positive and not negative tests, it'll inflate your positivity rate. But I think the last time I asked about it was probably less than 1% of the positive tests were antigen. So it's probably not inflated by very much. Now, you may have a bias toward, compared to a month ago, more people that are getting sick are testing as opposed to people that just want to test before they go to their grandmother's house. And if you're enriching the pool of people being tested, you probably will preferentially see that rate go up. But I think that, and none of these measures are perfect, by the way, frankly, Tom, even hospitalization, because we still have the issue that there are people admitted with non-COVID related conditions who test positive. So I think it's as it has been, but probably even more challenging now, a matter of triangulation. I don't think there's any question that what we're seeing now with RSV and probably what we're going to see with flu is related to, some have called it an immune debt, that we, for whatever reason, public health orders, decisions by individual folks to stay away from each other had very mild flu years and very mild RSV years. But yes, you're right. We are hearing, you made it all happen. It's all because of what public health did. It's, as you said, a complicated multi-hour kind of conversation.
Thanks.
As a follow-up to Dr. Faywell's question, I'm just wondering what the message is going to be for Thanksgiving and people gathering, as the weather gets colder and people are traveling, and given where we're going, what's going to be the message?
Well, it's funny you're asking me that. I'm so glad Becky's here, because I sent her an email yesterday saying, Becky, we need to come up with a healthy Thanksgiving message. I think that healthy Thanksgiving message is going to be get your vaccination. If you are traveling and being around other people, especially if they're vulnerable, be careful. If you're at a relative's house, take some rapid tests with you. I'm still a big proponent of masking in public spaces with poor ventilation. Especially, not the other night at our party, by the way, but as rates beginning to go up, certainly in airports, I think mask wearing is important. And then because RSV can be transmitted by adults, I do think the environmental surface hand washing protection message is more important than ever. We'll get that worked out though, because we want everybody to have a healthy Thanksgiving.
Okay, thanks. Not seeing any more hands raised. Let's move on to the executive director's report. There's some highlights you'd like to share with us, Dr. Douglas?
Yeah, I think the main thing I want to point out is that I want to thank MAME for continuing to help us track on our staffing situation. I think we're finally seeing that level off. Not all of our staff have got plans for the coming year. And I think that with those plans in place, we've got a little more stability than we've had. Number two, I want to thank the team, or rather those who, in the midst of all the craziness, made presentations at Public Health in the Rockies. Life actually still goes on. We had 3 of our colleagues make highly impactful presentations at that meeting. I want to thank our nursing program for describing something we really haven't talked about a lot lately, which is our breast and cervical cancer screening program. With all the communicable disease distractions we've had, preventing cancer has gotten a little bit pushed to the back, at least in terms of public visibility, but certainly preventing diseases for which there are great screening programs remains an important priority. And if you didn't make it all the way through Melissa Adair's excellent summary of our communicable disease situation, she's done a great job. And we are in the midst of many viruses at this point. So I think those would be the highlights.
Great, thank you. Questions, comments? Not seeing any. Jan?
I just had a quick question. What was the general subject of public health nursing in elevators? I was just curious what that referred to.
Melissa, I didn't get to go to the meeting and I read it, and I don't want to mistake it if you can do better. Otherwise, I'll take a crack at it.
Yeah, I'd love to hear your take on it as an honorary public health nurse, and then I can follow up.
Yeah, okay. Well, Jeannie made me an honorary public health nurse, Jeannie North, once upon a time when she had laryngitis like Julie and couldn't give her talk. And so I had to give it. I told her that was the deal. My recollection is it's everything you want to transmit about public health nursing during an elevator ride. And I don't remember if it was a 3-flight ride or a 4-flight ride, but it was short and sweet.
Yep. Yeah, it's the elevator speech on what a public health nurse does. It's a short speech, but it's something that's very impactful that they wanted to provide so that a lot of people don't know what public health nurses in particular do.
Okay, thank you. I just was curious. Now I understand you were talking more or less about an elevator speech.
It's not doing CPR on an elevator, Jan.
Right.
Well, it could have been.
Okay, great, thank you. Not seeing any more hands raised. Let's move on to the setting the agenda for the December meeting. There's been some question about why we need to meet in December. I believe it can be a short meeting. I think it would be helpful to have a wrap up to see where things are, what contracts have ended, what's the pending status of the legislation or the lawsuits, so we'll continue to work on that. Then the other suggestion was that from Sid that we could make a resolution to actually formally end Tri-County. So we'll work on the agenda. If there are any other topics that you would like to be sure that we include, you can let Julie know or let me know before our upcoming December meeting. And then hopefully we'll all see you on December 2nd at our upcoming dinner celebration. Let's see. So the next item is any board member remarks. Anybody would like to say anything before we move into executive session? Seeing any hands. Belle-Ann, before we do this, I think we decided that you could give an update on what your activities are as part of our public meeting. So
Actually, Kaya, I think that one didn't get moved, and we had decided that there
Oh.
were enough matters that we wanted to be sure we had legal counsel, that it was probably better in the executive session. Belle-Ann, is that, you and I connect correctly on that? I'm sorry that wasn't made clear.
And I apologize about not letting you know sooner.
no worries. We'll be talking to you, I'm sure, when we get into our executive session. As always, I'd like to thank my fellow board members who volunteer their time in service of keeping our citizens of the region healthy and safe. And many thanks to the Tri-County team as well, that they keep working hard to assure that vital public health services are available to our citizens of Adams and Arapahoe County. And as a final topic, the board will be moving into executive session to meet with the legal counsel about transitional planning, the status of leases, and personnel matters. So in accordance with the open meeting law, Sid or Randy, did you want to cite the provision that provides for client attorney consultation by the Board of Health? You're muted, Sid.
Sid, you're muted.
Yes, there we are. Yeah, I'll be glad to state that. Yeah, we're ready to go into executive session pursuant to Colorado Revised Statutes, Section 24-6-402, parentheses 4 into parentheses, and has to do with the attorney-client privilege that we would be invoking during this meeting. And therefore, it's our determination that the minutes of this meeting do not, or the activities and discussions at this meeting do not need to be recorded and should not be recorded.
Okay, thank you. Do I have a motion to move into executive session?
Kaya, I need to add to that a little bit, just to clarify a little bit. The attorney-client matters have to do with the some various pending court cases involving Tri-County, status and strategy of those cases. Also, since our receiver, Belle-Ann Riley's joining, she's going to be discussing the status of lease negotiations and possible strategy about that. Some personnel matters, and also the sale of assets. So I would add to Sid's statement that we're proceeding not only under subsection 4B, which has to do with attorney-client discussions, also 4A, 4E, and 4F.
Great.
And one more thing, Belle-Ann is under a court order, and so is Tri-County, that she makes presentations to the Board of Health, not to the public at large.
Thank you for that clarification. Do I have a motion to move into executive session?
So moved.
So moved. Second.
Any discussion? Great. All in favor?
Aye.
Aye. Anyone opposed? Great. Well, thanks. Let's move into executive session then. And